On-the-scene video coverage of TCT 2012 is supported by Pradaxa.
I'm Peter Block for On the Scene Video in Miami at TCT 2012. And we're going over the late-breaking clinical trials. I have two distinguished visitors with me today. On my far left, Deepak Bhatt from the Brigham and Women's, and George Dangas on my immediate left from Mount Sinai. We're going to go over the hot stuff that breaks today because this is the first day of late-breaking clinical trials. Deepak, I'm going to throw the first one to you. FAME2 cost effectiveness. Give me the short version.
Sure, so the FAME2 trial, of course, was a randomization of FFR-guided PCI versus medical therapy for stable disease. Main results published in the New England Journal of Medicine, and I thought very nicely, very unequivocally showed a reduction, a significant and large reduction in urgent revascularization with the FFR-guided strategy. What the investigators have now done with the cost-effectiveness analysis from FAME2 is extend those results and show that an FFR-guided strategy is superior to medical therapy in terms of cost effectiveness. So not only reducing the need for urgent revascularization, but essentially a very cost-attractive strategy, even though the initial costs are higher, because obviously they're using a technology, FFR, that's got some cost to it. But even with that, over time, with some assumptions and long enough follow-up, the therapy does seem to be cost-effective.
It's cost effective at the front end, and then at 1 year there's a 50% reduction, which actually slides it under the tag. George, tell me how much you think quality of life is worth per year, because that's what this boils down to.
Well, that's a tough question. In order to answer in some ways, we use a precedence and principle. And the hemodialysis cost was thought to be about $50,000 per year. So therefore, if the quality unit is under 50,000, then it's deemed cost effective. And for this particular case, it's around 30,000. So it is under 50. So it's a simple math from now on. The question in my mind is whether further follow-up is going to trim down this value or is going to augment it. And we'll have to follow up and see. If it trims it further down, that will be even better.
Well, the point is that they actually went against medical therapy, and these folks are going to come back with recurrent angina and so forth, which is what drives the cost up late for these. We'll see how it turns out, but it's an interesting trial.
But I think clinical practice also mirrors what they found. That is, if you've got somebody with a tight lesion and clear symptomatic angina and you just leave them alone, many times they do come back. They come back to the emergency department, and that ends up costing a lot of money, lots of downstream testing, and that costs money.
Agreed. Okay, let's go to the next trial, the MASTER trial, an interesting trial. MASTER is a trial of a stent that's covered with a micronet mesh to keep out all the bad stuff in acute myocardial infarction. George, give me your thoughts on this trial.
This is a very interesting study because we're talking about a new principle being coming into intervention. You have a stent which is already a metal cage, and around that now you have a mesh, as you said. And the stent is thought in thrombotic lesions sometimes to be embedded in the vessel wall and let the thrombus protrude, then may embolize distally. So the mesh is supposed to not allow that. And they did an over 400 patient study randomized in acute MI with a main principle to show that there was less more ST resolution, I should say, better reperfusion at 60 to 90 minutes, essentially an EKG criterion. And this was successful. And this was accompanied by improved TIMI grade flow, though not blush as much, and a trend in cardiovascular mortality. So all these three positive findings kind of make an interesting theme and a very positive theme about this device. The questions that are the one is why the blush didn't follow, why the MRI didn't follow, and one can say that measuring MRI in 3 days after an MI, there's a lot of edema and maybe a lot of inaccurate measurements there. And the third one is what's going on with that stent being not drug-eluting at this point. But I'm sure all those will be vetted out in subsequent. The main messages here were very positive.
Well, I'm going to take issue with that because I'm not so sure that's true, George. And Deepak, answer this question. I'm having a deja vu all over again because when we looked at downstream catchment of all this stuff with a regular stent, there was no difference in outcomes. And in fact, in this trial, when you look at clinical outcomes, ST resolution, I agree, George, but clinical outcomes are really no different. So what is this going to do for us, Deepak?
Well, you read my mind, actually. I was thinking of the embolic protection device experience in acute myocardial infarction, even the mechanical thrombectomy experience where lots of surrogate markers look good, clinical outcomes, debatable whether there's been an impact or not. And manual aspiration, a couple of big trials going on, still trying to nail that down. So I think there's a lot of instances of a dissociation between various surrogate markers and clinical outcomes. And when you measure multiple surrogate markers, some of them might look good. So I think there's some positive signals here, don't get me wrong, but I think there needs to be a larger confirmatory trial that's powered to look at clinical events, including long-term events. And the field is shifting. Right now, the second generation drug-eluting stents in acute myocardial infarction as well look pretty good. The event rates are pretty low. Stent thrombosis rates are extremely low. So it's actually going to be a high bar to cross to do better than those generation drug-eluting stents.
Let's move on to a third trial, the ISAR-LEFT main. So who wants to take this one? George, you want to take this one first?
Of course. ISAR-LEFT main is very, very interesting now. This group went ahead and compared left main to bypass, comparing now two different stents for left main. And interestingly enough, all kinds of left main, including mostly distal bifurcation left main disease, and found not a whole lot of difference between the two, both of them second generation DES. All the numbers were lower with the everolimus stent and a little higher arithmetically, but statistically were very similar on all counts. So there's a discussion of statistical power here, and is there a small difference that went undetected because the study didn't have thousands and thousands of patients? Or really we're talking about two technologies that can be very, very durable, even in this very complex patient population, although not lesions sometimes, are left main.
Deepak, I hate to say it, I know the drug companies want to have, or the stent companies want to have their drug-coated stent a little bit better than their competitors and so forth, but aren't we getting a little tired of this, my stent is better than your stent kind of stuff?
Yeah, I think as a general class, drug-eluting stents look pretty good for left main disease, and there are ongoing studies that'll nail down, how much better or equivalent, non-inferior they are to surgery. But I actually would say that the second-generation drug-eluting stents, there is an advantage over the first generation. There do seem to be lower rates of stent thrombosis. An infrequent event, which this trial, though well-designed, probably not powered to really see those sort of differences. Also in this trial, the majority of left main lesions were treated with a single stent, which is good. Should try to avoid bifurcation stenting when possible. But if bifurcation stenting is needed, clearly the risk of stent thrombosis is higher. Maybe some differences between these types of stents would have emerged. There's certainly some data from the recent examination trial in acute myocardial infarction that the second generation everolimus stent had a statistically significantly lower rate of stent thrombosis than a bare metal stent. So I do think there's something to these second generation drug-eluting stents.
Okay, that's 3 good trials, and we'll be right back.